Welcome to Think Like a Nurse, the video outreach of Keith RN. Today's topic, hunting for sacred cows. Here in Minnesota, this gun would typically be used to bring down a white-tailed deer. But I have no desire to go after a buck today. This gun was especially made for Keith RN to bring down a cow. Not just any cow, but sacred cows. But not just any sacred cow, but the sacred cow of nursing and nursing education, NANDA, or North American Nursing Diagnostics Association, and their 205 nursing diagnostic statements. Now, I don't want to destroy this sacred cow, but only just to shoot it down at the knees and bring it down a notch or two from the blind reverence and devotion that so many in nursing education have to see it more clearly for what it truly is, just one way of defining the body of nursing knowledge, but deficient to capture the essence of how a nurse thinks and prioritizes patient care and practice. If we can be honest and acknowledge the shortcoming of NANDA, then we can begin to embrace other ways that capture the essence of nurse thinking, including clinical reasoning, based on the work of Patricia Benner and her co-authors in Educated Nurses, and her follow-up book on clinical wisdom. That is an exceptional way that reflects thinking in action. Now, for over 30 years, NANDA has been the taxonomy of defining the body of nursing knowledge, and I have no problem with that. But their official website says some things that I believe ought not to be bought, hook, line, and sinker. On the official website of NANDA, they state the following: the purpose of NANDA is to represent nurses' professional clinical judgment and promote terminology that accurately reflects nurses' clinical judgments. But is this true? Do nursing diagnostic statements accurately reflect nurses' clinical judgments? I would go a step further and honestly ask, does nursing diagnosis statements capture the essence of how a nurse thinks in practice to prioritize care needs and rescue their patient if there is a change in status? I believe that we must be honest with our students and let them know that the current 205 nursing diagnostic statements that are wrapped into 13 separate domains and 47 classes are unable to capture the essence of how a nurse thinks in practice and identify the patient care priority, especially when there is a change in status. Now, NANDA has a place as one way that captures a patient's response to illness and how a nurse develops a plan of care. But this approach is best suited for stable patients with expected responses to treatment. And we know, especially in acute care, that this can never be assumed or expected. The greatest weakness of NANDA is the inability of this taxonomy, again, to reflect nurse thinking when a patient's status changes. This is the strength of using the principles of clinical reasoning as a template for nurse thinking, and de-emphasizing NANDA as our only taxonomy of nursing knowledge and language that can be used by our students to guide patient care. The essence of clinical reasoning is the ability of the nurse to recognize that there is a problem, and once we identify that problem, what are the nursing priorities with this status change? My first criticism of NANDA, if I were to summarize, is that it does not reflect how a nurse thinks in practice. Now, does a three-part NANDA statement with the correctly chosen nursing diagnostic statement with its related to and as evidenced by reflect how you practiced and thought when you were at the bedside as a practicing nurse? As a nurse educator for myself who never left the bedside, I have never been comfortable with the emphasis that my colleagues placed on NANDA language and allowing these three-part statements to be the only way to establish a plan of care in the clinical setting. NANDA does not capture the nuances and priority setting that I have used in the clinical setting for the past 30 years. Yet I felt torn to allow my students to agonize with their NANDA handbooks, trying at times to find a statement that fit their patient just right. It felt like it was putting a square peg in a round hole many times. But am I the only educator who feels this way? Are there others who have not drank the NANDA Kool-Aid? I hope not, and I don't think so. Here's a real-world example from my clinical practice that'll let you decide if NANDA reflects clinical judgments. I recently was the first to respond to a cardiac arrest code on the floor. As I looked at the patient and saw an ashen pale person with no spontaneous respiratory effort and no pulse, did I step back and think NANDA, ineffective tissue perfusion, cardiac, neuro, and renal, related to ventricular fibrillation. But oops, I cannot use the medical diagnosis. I must instead state that this is a condition in which there is uncoordinated contraction of the cardiac muscle of the ventricles in the heart, making them quiver rather than contract properly. And this is manifested by absence of pulse, absence of blood pressure, and ashen pale skin color. Now this may get an A on a care plan for a properly stated all three components of NANDA statement and the verbiage that goes with it, but it fails to prepare our students to think like a nurse. Simply stating what is my nursing or care priority captures the essence of how I thought in practice in this situation and how most nurses think in practice. So in the example of the cardiac arrest, I would simply think as my nursing priority, no pulse, no respirations, therefore I need to begin CPR. The second point of my criticism of NANDA is it's unable to capture the essence of a patient's changing status. For example, if your patient on the medical floor has a post-op patient on a Dilaudid PCA or any narcotic medications that has now become lethargic and unresponsive because of their narcotics, but they have a respiratory rate that is still within range, what is my NANDA nursing diagnostic statement? I reviewed it over and over. I could not find one statement that accurately fit this common clinical condition. But if my respirations were deficient, like 6 to 8 or 10, then I could use NANDA language of ineffective breathing pattern related to the oversedation of narcotics and depressing the central nervous system as evidenced by their unresponsive to physical stimuli. But is this preparing our students to think like a nurse in the quickly changing dynamics of clinical care? I don't think so. Versus if we emphasize nurse thinking and clinical reasoning by simply stating opiate oversedation. Then the interventions readily follow. We give Narcan, monitor airway breathing in their response to this, and therefore rescue our patient. My third criticism of NANDA is that it may contribute to a failure to rescue based on what I just stated in point number 2. Even Dorothy Del Bueno, regarded nurse educator, stated in her published article, A Crisis in Critical Thinking, states the same concern. She says, many inexperienced RNs also attempt to use a nursing diagnosis for the problem focus. Whatever their original intent for its use, the results are at best cumbersome and at worst laughable. She identified this problem in her research with new nursing graduates that included misuses of nursing diagnostic NANDA language as a priority problem based on their assessment in a simulated scenario. And she cited some examples saying that when a patient had an active change of neurostatus reflecting a stroke, they would use NANDA language of alteration in sensory perception or alteration in nutrition. Clearly laughable and not capturing the essence and the urgency of what's taking place. With a patient with MI, students used, or new graduates would use, they have an activity intolerance related to pain. And again, if the only taxonomy we're using in our education is NANDA, this is part of the problem, and we must open the doors to recognize there is more than one way to teach our nurses to think, and clinical reasoning must be a part of it. The other point that is a concern, that we look at nursing priorities. Now, a nursing priority is a better way. and it reflects the essence of clinical reasoning. Identifying the nursing priority and not NANDA language is going to prepare our students for practice. I would say, please, if you have not read Patricia Benner's Educating Nurses or her follow-up book, Clinical Wisdom, make this required reading. This will lay a foundation of this educational research and her own observation of interviewing nurses in practice to see how they think and the principles we can learn. The first strength when we look at using nursing priority and clinical reasoning is that it identifies the care priority, concisely capturing the problem. Now again, we need to be honest and say to our students that concisely stated priority statements can reflect good nursing care. We do not need to use NANDA and looking for, again, that worst possible complication that oftentimes can happen reflects clinical reasoning and reflects, more importantly, how a nurse thinks in practice. Now this will serve their patients better than having them go over their list of NANDA statements over and over trying to find something that will fit. For example, in the dramatic but real-life example of this cardiac arrest that the nurse encountered when she goes into the room of a non-monitored medical patient, no pulse, no respirations, clearly captures the essence of our problem. This is all that is needed in a crisis. Another example of the relevance of this approach is that where I work clinically, the EPIC platform is the dominant electronic medical records that is used in the Midwest. In the care planning aspect of EPIC, the nurse must chart each day what is the care priority today in discussion with the patient and family. It does not ask for your nursing diagnostic priority, and there is a difference. By emphasizing care priorities, we are preparing our students for real-world practice. Now, the second strength of using nursing priority is that interventions readily follow. Again, Care Planning 101 is wrapped up in clinical reasoning as well. When we say, for example, no pulse, no respirations as our nursing priority, what do we do next? Well, it's obvious. We begin CPR, and therefore life-saving interventions can quickly begin. Now, the third strength is the rescue of the patient is facilitated. Instead of hesitating and ruminating for a correctly worded three-part NANDA statement that will help direct and guide care, this problem has been concisely stated with our cardiac arrest patient, and we can begin to initiate life-saving treatment. But another more common example, if your student has this post-op patient on a dilaudid PCA that has now become lethargic, simply stating that, oh, they must likely have opiate oversedation based on the fact that they're on a PCA of narcotics captures the essence of the problem, and therefore they can begin to administer and recognize, what do we do with opiate oversedation? We must counteract with giving Narcan, and therefore administer and assess and evaluate their response. In closing, Dorothy Del Bueno asked this question in A Crisis in Critical Thinking. Why can't new registered nurse graduates think like nurses? Only 35% of new RN graduates, regardless of their educational preparation, meet entry expectations for clinical judgment. Although well-versed in content, the majority are unable or have considerable difficulty translating knowledge and theory into practice. Now, in addition to too much content in our nursing programs, I believe that another contributing factor to our graduates' current inability to think like a nurse is our current emphasis on NANDA, nursing diagnostic language, to center our plan of care and nursing priorities. To transform nursing education and teach our students to think like a nurse, we must emphasize and embrace clinical reasoning and its obvious strengths that mirror how a nurse thinks in practice. Clinical reasoning is nurse thinking, and it reflects the ability of the nurse to establish appropriate care priorities and to analyze relevant data and make clinical judgments and decisions when there is a change in status. We will compare and contrast NANDA with clinical reasoning another day, but today, be the change. And check out the template of clinical reasoning questions on the link to this video. It can be used with your students in the clinical setting and see for yourself the difference that this makes to promote their learning and nurse thinking. In fact, I would encourage you to use this one-page template, remove the care plan for that day from your current paperwork, and just see for yourself. If you want to take the plunge and use clinical reasoning with your students, please go to my website, KeithRN, and go to the Clinical Resources tab. Then go to the Clinical Reasoning folder and explore the clinical paperwork that are all in Word documents that I have created and have been found to be successful and promote the learning of my students in the clinical setting. As with all my downloads, my copyright is your right to copy, as long as it is used in the educational setting to promote the learning of your students. Together, we can realize Patricia Benner's transforming vision of nursing education to not only promote the learning of our students, but more importantly, better outcomes for the patients they care for.